VQ mismatch is a critical concept for the boards, and we've already alluded to it a couple of times during this talk. In this concept, V represents ventilation, while Q stands for perfusion. The ideal situation is that ventilation is perfectly matched to perfusion, and thus a VQ ratio of 1. So what happens in the typical person? Well, at rest, lying down, the average person maintains 4 liters of ventilation for about every 5 liters of blood flow, giving an overall VQ ratio of 0.8. However, in a standing person, there's a variation in the VQ ratio thanks to gravity. So let's look at this in a bit more detail. When you're standing, ventilation is much greater than perfusion at the apex of the lung, so you see wasted ventilation. What kind of dead space occurs here? That's right, functional dead space. The wasted ventilation is the reason oxygen-loving bugs like TB tend to end up in the apex, and perfusion is greater than ventilation at the bases of the lung, where you get wasted perfusion. As you can see, perfusion is a function of the interaction between pulmonary artery pressure, pulmonary venous pressure, and alveolar air pressure. It is worth noting, however, that both absolute ventilation and absolute perfusion are greater at the base of the lung than at the apex. However, gravity increases perfusion more than ventilation. Now, let's talk about the extremes of VQ mismatch. A VQ of 0 represents a complete shunt, in which there is perfusion, but no ventilation. So what are some examples of this? Well, you see this shunt with status asthmaticus and airway obstruction, like in mucus plugging. And in these cases, increasing the fraction of inhaled oxygen does not really improve arterial PO2. On the other hand, dead space ventilation represents a VQ mismatch that approaches infinity. In this instance, there's ventilation, but there's no perfusion. So Q equals 0, because the blood doesn't flow into this well-oxygenated alveolus. So what's a clinical example? Well, a massive pulmonary embolism would be the classic example. In this case, giving the patient 100% oxygen should improve the PO2, except the blood's not really going anywhere. So far, we've talked quite a bit about the role of oxygen in pulmonary physiology. Just as important, however, are the mechanics of carbon dioxide exchange. From the acid-base physiology material in the renal section, remember how the lungs and kidneys work together to maintain homeostasis in the human body. Carbon dioxide is transported from tissues to the lungs in 3 forms. The majority of CO2 enters the red blood cell and is converted to carbonic acid by carbonic anhydrase. The hydrogen ion dissociates, and what are you left with? Bicarbonate. The remainder is either bound to hemoglobin as carbaminohemoglobin or as dissolved CO2. Now, let's talk about some key physiologic concepts involving CO2 and oxygen transport. The Haldane effect describes the phenomenon in which CO2 is released from red blood cells. In the lungs, oxygenation of hemoglobin causes dissociation of H+ ions, which can then combine with bicarbonate to form carbonic acid, which then splits into CO2 and H2O with carbonic anhydrase. So, what's the bottom line? Well, this is the opposite of what happens in the peripheral tissues, and basically, the greater presence of oxygen in the pulmonary circulation causes CO2 to be released, and it can subsequently diffuse into the alveoli and be exhaled. Do you recall the Bohr effect? As we alluded to earlier, the Bohr effect is when the increased H+ ion concentration in the peripheral tissues shifts the oxygen-hemoglobin dissociation curve to the right and favors oxygen unloading into the tissues. Finally, I'm going to talk a bit about the chloride shift, which is not discussed in first aid. When you make a lot of bicarb, it has to go somewhere. The red blood cell can exchange negative bicarb ions for negative chloride ions to maintain electrical neutrality. And like the hydrogen ions in the Bohr effect, the chloride ions also have a negative allosteric effect on hemoglobin, causing it to dump oxygen in the peripheral tissues. These are some super high-yield concepts, so you should rewind and review this video until you completely get it. Got it? Great. Let's do a flash quiz. In mucus plugging, you would expect VQ to equal 0. Ventilation approaches 0, since there is no air movement, but Q, for the most part, is unaffected. This topic is high yield because the physiology is so clinically relevant and testable, so be advised that this can definitely show up on the exam. Alright, so you probably already know that athletes often train at high altitudes for better speed and endurance. But do you know why? You get increased minute ventilation, since there's less oxygen content in the air at higher altitudes. Here, you can see the alveolar partial pressure of oxygen is low compared with sea level. Gradually, the body adapts to altitude by producing more erythropoietin. Where is erythropoietin produced? In the kidney. And what does it do? It increases the hemoglobin and hematocrit in response to chronic hypoxia. As we mentioned earlier, there is also an increase in 2,3-BPG, which does what again? It decreases the affinity of hemoglobin for oxygen by stabilizing the T or TOT form of hemoglobin, which promotes unloading of oxygen to the tissues. At the cellular level, over time, you see more mitochondria and an increase in the concentration of mitochondrial enzymes to improve efficiency of cellular oxidation. Once you go from acute to chronic hyperventilation, you get a respiratory alkalosis, which is countered by an increase in renal excretion of bicarbonate. As you remember from the first aid renal pharm section, we give acetazolamide to treat acute mountain sickness by forcing the kidneys to waste bicarb. From a cardiovascular standpoint, chronic hypoxia leads to pulmonary vasoconstriction, and over the long run can cause pulmonary hypertension, and also right ventricular hypertrophy. Finally, I've mostly talked about chronic changes in the lungs, so I'll just mention that in addition to acute mountain sickness, a rapid increase in altitude can lead to pulmonary and cerebral edema, and this is thought to be secondary to increased arterial and capillary pressures and increased capillary permeability. It is a much feared condition of mountain climbers, and is the reason why people who attempt Mount Everest stay at base camp for a few weeks before summiting, in order to acclimate at 17,000 feet, right before their rapid ascent to the summit. So let's wrap up respiratory physiology with exercise. What happens when you exercise? Well, obviously, there's increased oxygen consumption and increased carbon dioxide production. And, as you know, ventilation rate goes up to meet this increased oxygen demand and carbon dioxide production. And more specifically, there's an increase in both ventilation and perfusion. Also, the VQ ratio from the apex to the bases of the lungs becomes more uniform. So exercise causes vasodilation and recruitment of the apical capillaries. So the pulmonary blood flow you see occurring in zone 3 occurs in the other zones as well, despite gravity's usual effect. As cardiac output increases, there's a proportional increase in pulmonary blood to support more efficient exchange of oxygen and carbon dioxide. Interestingly, there's no change in PaO2 or PaCO2 because of the efficient gas exchange, but there is an increase in venous carbon dioxide content. Finally, there's also a decrease in pH because of lactic acid production. So to recap, what does this do to the oxygen dissociation curve? It shifts to the right. This allows the hemoglobin to unload oxygen in the tissues where it's needed the most.